Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. I would like to thank the organizer and the sponsor for this very important meeting. Today is the first episode of the clinical dilemma in atherosclerotic cardiovascular disease management. We have really very prevalent disease, and the number one killer in the kingdom here is cardiovascular disease. And really, we have to work hard in order to prevent this, because the risk factor which is really contributing to our disease is very common. And in order to prevent the atherosclerotic cardiovascular disease, we have really to know how to know the factor which is contributing and try to prevent them from early. Today we have very special talk and very special speakers actually. We have two eminent speakers, one from the Italy area and one from the kingdom here. I would like to introduce the first speaker, the Professor Alberto Cabatino. He is a professor of pharmacology, director of the study atherosclerosis center in Battle Hospital in Milan. He will address to us the guidelines for lipid lowering, present status, and future challenges. The talk will be for about 25 minutes, and then we will have enough time for discussion. So please, I will urge all those who are with us to send their questions so we have a very fruitful outcome from this meeting. So without any further delay, please, Professor Alberto.
Thank you. Thank you very much for the kind introduction. Today, I'll speak to you briefly about guidelines for lipid lowering, the present and future status. This slide depicts for you my current conflict of interest related to this presentation. Now, what are the fundamentals of guidelines? First of all, that LDL is causal to the disease. So this is the point that has been made. And the second point that is fundamental to guidelines is the background reflects the concept and what we know that independent the way we reduce cholesterol, we get benefit, and the benefit is proportional to the reduction of LDL cholesterol. In other words, the more you reduce, the better will be in relative risk reduction, the outcome. This is supported also by genetic studies. If you look at this slide here, depicts for you the genetically determined lower LDL cholesterol. This is coming from a paper with Brian Fearens that indicates for you some of the key polymorphisms that regulate LDL cholesterol. Being that polymorphisms, they affect quite to low amount LDL cholesterol, but lifelong. And if you can plot those polymorphisms, this is one that decreases PCSK9, for instance. This is one that decreases Niemann-Pick-C1, that is the target for Ezetimibe, and so on. You can see there is an absolute magnitude lower LDL, lifelong, that results in a reduction of LDL cholesterol, of events. In addition to that, when you put them together, they add up, indicating that associating this type of intervention on those targets will bring an increasing of the reduction, relative reduction of risk. This is better depicted in this slide as part of the consensus we made on LDL with the European Atherosclerosis Society, which I contributed together with Brian Fearens. And this depicts for you the benefit from 1 millimole reduction due to randomized controlled trials with drugs, including statins. And you can see here you get for millimole reduction of LDL, roughly 40 milligrams, 38.7 milligrams per deciliter, a 22% reduction in relative risk of cardiovascular events, ischemic cardiovascular events. If you do the same exercise in prospective cohort studies, what you see is with the same 1 millimole, the reduction is larger. Why? Because there is more time in this observation, 12 years. And if you do the Mendelian randomization, when you have 52 years of follow-up, 1 millimole will result in a 52 to 53% reduction of the events. This is entirely consistent with throughout groups This is for clinical trials, but it's true also for Mendelian randomization, independent whether you have a starting high level of LDL cholesterol or lower level of LDL cholesterol, independent of age, independent of sex, independent of being at high or very high risk. The relative risk reduction is proportional to the decrease in LDL cholesterol. However, there is one point we need to bear in mind that relates to the length of the observation. If we run clinical trials and we separate year by year the benefit of 1 millimole reduction, you can see here quite well that during the first year, the benefit doesn't come to these 22 to 23% per millimole, but is much far less. Why is it so? We do not know, but that has been reproduced not only for statin, but also for PCSK9 inhibitors, also for Ezetimibe, you name it. So that means when you run a trial, you have to take in account, or when you make an observation, that during the first year, the effect will be less while reducing LDL cholesterol. And this will be even more important if you have a short study. The key point in the guidelines, however, is this one. The interaction between the LDL cholesterol reduction and the risk in terms of number of events. So the relative risk reduction versus the absolute risk reduction. In other words, a drug that reduces by 1 millimole LDL cholesterol will spare 170 events if you were to treat people with a moderate risk out of 10,000 patients treated, or 730 if those were a very high risk. And therefore, the number needed to treat will widely vary, here being around 14, here being about 70. And that the same drug will give you a completely different outcome in terms of what you think about it. Exactly the same if you were to reduce by larger amount LDL cholesterol. So you can see here by 2 millimole in the very high risk people, you will spare 1,440 events. That means roughly a number needed to treat of 7, which is quite a good number. So the bottom line for LDL and for other condition there is the following. Genetic, epidemiological, and trial evidence indicates that LDL cholesterol is causal. Trials of LDL lowering indicate relative risk reduction is proportional to the absolute risk reduction, and lower is better. So intensity of therapy should be based on risk and decreasing LDL cholesterol as much as possible. What are the conditions for very high risk? Well, you have seen that in the guidelines. I'm not going to recapitulate that. And all the guidelines report this classification. Essentially, people with presence of cardiovascular disease, will that be an event, and or presence at instrumental level will be in a very high risk condition. Then there are the high risk, the moderate risk, and the low risk condition. I will refer you to the guidelines to select this population. But what really matters here is how to treat them. And taking advantage of the concept we have made before, so the higher the risk, the larger the benefit you will experience. What I really suggest here to you is our approach. So if you are at low risk, you can have interventional lifestyle and intervene only when LDL cholesterol is high. However, as the risk gets higher and higher, you have to start immediately with a high level of intervention, both lifestyle and drugs. And as you may see here, the level of the LDL at which we suggest to start with the intervention becomes lower and lower according to the risk. And it's reflected here in a more simple way, if you will, whereby with the very high and high risk people, we suggest goals of 70 and below 55 milligram per deciliter, 1.8 and 1.4 millimole per liter. And another goal of at least 50%. So please bear in mind, for people high and very high risk, there are two goals. One is the number, second is the percentage reduction. What are the issues that we will be facing in the future? Well, certainly lifetime risk. We are relying on tables like this, that's the score, where age dominates. So the higher is the age for 10 years perspective, the higher the risk. And therefore you tend to be over-treating people at older ages, because the 10-year perspective of a person at 70 years is much worse in terms of cardiovascular events than a person at 40 of age, even though they have the same setting of risk factors contributing to the risk. In the current view of the new score, with different regions were included, as you can see here, what has been recommended is a sort of mediating this, trying to lower the threshold at which people is considered at very high risk. You can see here, above 15 for the people above 70 years, and above 7.5, half of it for people at younger age, below 50. And that is recapitulated as an image here. You can see how this level of very high risk changes according to ages. Will that suffice? No, not really, but that's a first step towards it. Ideally, we should be able to make the calculation of the absolute risk. HDL. HDL has been a long story. We recommend HDL to be part of the risk evaluation, yet is not causal. That's the bottom line. Most recent data have indicated that there is a sweet point for HDL for male and female. That's cardiovascular mortality, but also for infectious diseases and others in this area between 30 and 70, 80, and for females between 40 and 80. While at the extremities there, the risk of cardiovascular event increases for both sexes. So that's very important to understand. Please consider not a good idea to try to increase HDL and not to be so worried when HDL is low to increase them. What you should do is to decrease the factors that are known to be causal in cardiovascular events. HDL or ApoB in everybody? Well, as you may remember, triglycerides were sort of wiped out by these studies, the emerging risk factor collaboration, where non-HDL, which is essentially all the ApoB containing lipoprotein, was present as a risk factor, also corrected for all the variables, while triglyceride, and adjusted only for age and sex analysis, were a strong factor, but adjusted for several other risk factors disappeared. Unfortunately, this adjustment was made for non-HDL as well. That means that they took away all the cholesterol that is carried in triglyceride-rich lipoprotein, which is correlated with triglyceride. That's why triglyceride disappeared. And therefore, this is something that needs to be considered. Nevertheless, ApoB performs as much as non-HDL cholesterol, as you can see here. And in a Mendelian analysis, it also is even better than everything else. So in other words, ApoB may be the future. As you can see here is in this stepwise Mendelian randomization analysis, ApoB is the only one that stands alone up to this analysis over and above both triglyceride and LDL cholesterol. Lp(a) has become of fashion recently because new drugs are becoming available to decrease Lp(a). Lp(a) is a causal risk factor. The point is how much should we treat, how much we should decrease Lp(a) in order to achieve a benefit. Well, obviously, if you look at the correlation in population, but also in Mendelian studies, by tripling Lp(a) levels, which vary from 3 to 192 here, you increase the risk by 16%. If you do that in a much less wide interval for LDL, you increase by 400% almost. Is that any reflection on how shall we treat? Well, certainly, because definitely 100 nanomole lower Lp(a) we contribute to 33% relative risk reduction, but that 100 nanomoles means roughly 40 milligrams per deciliter. 1 millimole is 50%. So if you were to make a calculation for a reduction 5% in lifetime risk of CHD, you will have to address Lp(a) at levels of reduction of 80 to 100 milligram per deciliter, 200 nanomoles roughly, in front of the same benefit with 1 millimole for LDL cholesterol. Percent reduction versus goal, both of them are important. It's stressed here. Why? Because if you have a very people with high cholesterol, the goal is there, let's assume you have a person 150 of LDL, very high risk. If you go down to 155, you decrease by about 100 milligrams per deciliter, more than 2 millimoles, benefit about 45%. However, if a person naturally has an LDL of 70 and experiences myocardial infarction, reaching below 55 is not enough. Going, for instance, from 80 to 55 will be 25 milligrams per deciliter, not a large benefit, 18%, 17% expected. However, if you were to reduce by 50% or more, let's say 50%, more than 1 millimole, the reduction will be 22 to 25%. This is the reason why these two numbers are together, number plus reduction in percentage. And that's very important to the benefit of the patient. Should we be scared going low? Not really. I mean, obviously there is the law of the reducing returns. As you go lower and lower, the actual absolute benefit gets lower and lower. Yet, if you go down, you still get the benefit there. And the safety is there. So there is by no means any data indicating that if you were lower in a trial than, let's say, going to 10 milligrams per deciliter, even with the evolocumab, this has been reported, you have no specific adverse events that are emerging related to the level of LDL cholesterol that has been achieved. And our guidelines are really on the top of the other guidelines and are concomitant indicating two different goals as well as secondary endpoints. One of them is the ApoB. And this is mirrored with less aggressive, if you will, approach by Canadian guidelines. But we are the only one that suggests also for people with diabetes, people with metabolic syndrome, secondary goals to be achieved. And this is non-HDL cholesterol and or apolipoprotein B. The trial design, as I mentioned to you, if you look, for instance, at this kind of trial, what you see is with evolocumab, the expected effect was less than expected from what we said, 1 millimole, 22% reduction. However, consider the length of the study, that was less. You had to pay a price that I showed to you for the first year. And when you run a short trial, you have to deal with that. And these are the lines you expect for 1 year, 2 years, 3 years, and above. And then if you plot a meta-analysis of PCSK9 studies, then these studies end exactly where you would have expected them for the length of the trials. Stepwise approach, the guidelines have suggested this kind of approach. First a statin, then ezetimibe, then a PCSK9 inhibitor, if you don't get the goal at each step of them. However, already in the guidelines, the first two steps have been incorporated, and this is clearly stated. If you are far away from the goal and you can predict not to be able to reach the goal, for instance, is more than 55% away from where you start with the LDL, just consider starting with a combination. Now, when you go here to PCSK9 inhibitors, in the guidelines, only the monoclonal antibodies are mentioned because at that point, small interfering RNAs were not available. Nowadays, at the second step, Inclisiran will be in the future guidelines probably included. Are we good in achieving the goals? Not at all. This is the Da Vinci analysis for where we stand. And as you can see here, either with the 2016 guidelines or 2019, we are terrible in achieving goals. But there are several reasons for that. First of all, because sometimes also by using high intensity statin, we do not achieve the goal. Yet, combination therapy is very poor in people with established atherosclerotic cardiovascular disease. Combination with PCSK9 is minor. And we even use moderate intensity statin. 44% of the patients are treated with moderate intensity. We will never be able to get there. And this is a very important point to bear in mind. Now, we are facing a revolution nowadays in different ways of approaching new goals and new therapies. However, what is really important now to reduce LDL cholesterol, which is here with PCSK9 inhibitors, we have different possibilities. So RNA interfering or monoclonal antibodies, as well as CRISPR-Cas modulation, which is still experimental. Now, Inclisiran is available, small interfering RNA, and this activity, as you know, is targeted directly to the liver, but this small interfering RNA that is captured by the asialoglycoprotein receptor that binds these GalNAc residues here and is taken into the hepatocyte specifically, where through the RISC complex, it inhibits the RNA from being read. So you destroy the RNA and you don't make the protein, you don't make PCSK9. So, and the contrary of what we have with monoclonal antibody, which block the PCSK9 outside of the cell, and you increase the plasma total level of PCSK9, in this case, you decrease by more than 70% PCSK9 levels in circulation. The endpoint is a 50% reduction. Will that increase these approaches, these new approaches, adherence to therapy? Well, the common consensus is probably yes. Why? Because we do know that with statins, for instance, and that's an old paper, but it's not that far from what we have now, you have a very doubtful adherence to therapy, and people tend to have between 40 to 50% adherence after 2 years of follow-up. And these are the results in total mortality. If you have low adherence, the delta with people high adherence, which are few, is very, very large. It's about 40 to 45% difference. What we can do with new drugs? Well, if you think of the small interfering RNAs, this is what is happening to LDL cholesterol. For instance, Inclisiran here, 2 doses per year. Will that affect adherence? Well, we know it's poor with statin. Those are once-a-day medication. We know it's getting better, but not that much also with monoclonal antibodies, but that needs to be confirmed. Potentially, 2 doses per year may be the solution. Will that be real data? We do not know, but we have a good background in order to be able to start with that. Thank you very much, Dan, for your attention.
Thank you, Professor. We enjoyed your talk actually, and we have many questions to be addressed, hopefully at the end. Now, our second speaker is well known in the kingdom here, Professor Mervet Al-Asnaj. She's director of the catheter lab at King Fahd Armed Forces Hospital in Jeddah. And she's really very involved in many work, actually. She's working as the leader of the woman group in the American College of Cardiology from the kingdom here. And she has written an article about how to improve our management of hypercholesterol in the kingdom. She will address the LDL cholesterol improvement initiative in the kingdom of Saudi Arabia. Please, Dr. Mervet.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Mervet Al-Asnaj, and I was tasked today to discuss atherosclerotic cardiovascular disease. And what I'm going to do is add what is actionable. When we look at the burden of atherosclerotic cardiovascular disease in the kingdom in general, we have to understand the scope of the problem. That's the number one issue. We have to assign individual responsibility, whether it is for patients or physicians, and assign collective responsibility, whether it is the individual healthcare centers or the public sectors, meaning medical societies, Ministry of Health, Saudi Commission for Health Specialties, and so on. So let's dive into this together. Looking at the scope of the problem and understanding the burden of the disease, the root of it is the healthcare system has to prioritize atherosclerotic cardiovascular disease, has to endorse initiatives and allocate the expenditures that are necessary. But along with that, it's important that physicians are aware of the problem and its magnitude and understand the guidelines and adhere to them. But there's also patient awareness that is important. Patients need to prioritize their cardiovascular health, and they're always at this point in time prioritizing other issues such as cancers and even COVID. They have certainly overshadowed cardiovascular disease, although it remains the number one killer in the kingdom, even during the COVID era. So when we look at it as the leading cause of death everywhere in the world, including the kingdom, over 18 million cardiovascular deaths account for a third of all the mortalities around the world. And when we look at ischemic heart disease and ischemic stroke, they are the number one causes of cardiovascular deaths, which are preventable. And when we move to the Kingdom of Saudi Arabia very specifically, among the 6 Gulf Council countries, Saudi Arabia has the highest mortalities. And cardiovascular deaths account for approximately 46%, superseding cancers and other non-communicable diseases and communicable diseases. But when we look at the health expenditures, the Saudi kingdom actually has the highest expenditures compared with other Gulf countries. And the leading risk factor for cardiovascular deaths remains dyslipidemia, which means this is what we really should be targeting at this point in time. Over a half of the population actually have more than 3 risk factors, and a quarter have more than 2 risk factors, which means there has to be a multi-pronged approach to this dilemma or this disease. Individual responsibility. So as I said, the system has to elaborate the guidelines, has to prioritize and standardize the cases. We need to all be speaking the same language. But at the same time, physicians have to understand these guidelines, and ultimately patients need to self-reflect and need to own their own health and take responsibility for their own health as well. If we start with the patients, we know we've become the Xbox generation, the iPhone generation, and the Snapchat generation, and we see our patients and our children gaining weight. And so we're actually seeing a much higher rate of cholesterol, increasing cholesterol with all the diet that we have and sedentary lifestyle. We're seeing across the world, but in particular, when you look at the kingdom highlighted in red, whether for men or for women, a higher incidence of diabetes and impaired glucose tolerance. We're also seeing a growing number of smoking, particularly in women in the kingdom. And so these have to be addressed. But as we move on to individual physicians, what do the physicians need to do? Physicians need to understand the role of lipid-lowering agents, need to understand the association of LDL with cardiovascular outcomes. And when you actually look at a young population such as that in the Kingdom of Saudi Arabia, what you do see is there's a very steep incline in the hazard ratio as the LDL level and total cholesterol increase in the younger age. It's much less steep when you go up in age in 80 to 89 years of age, and much steeper as you see here in 40 to 49, which means we need to be starting very early this kind of management and understanding that there's something called lifetime management of atherosclerosis and dyslipidemia. And overall, these have been published from over a decade ago. We know we're not doing very well. So even when the guidelines were actually very loose with an LDL target in high-risk patients of less than 100, 23% were not at goal. When we look at the more recent guidelines, looking at high-risk individuals, and the guidelines now recommended less than 70 in 2013, again, 76 were not at goal. The goalpost has actually moved even further, and the latest European guidelines have moved it to 55 milligrams per deciliter. You can only imagine what we're doing. And this is only for high-risk patients. We're not discussing familial hyperlipidemia. So we as individual healthcare professionals need to understand not only the guidelines, but understand the efficacy of these therapies that we're giving and examine the outcome data very carefully and hopefully generate our own healthcare outcome data. When we look at stable coronary artery disease, for example, and we looked at optimal medical therapy to reduce and to prevent cardiovascular events by lowering LDL, hypertension, etc. And we look at interventions, stents plus optimal medical therapy, you do realize that there's a cost to the system and a cost to the patient for these interventional procedures. And yet the natural history does not change very much. But we do end up increasing the cost of these stable patients. This is not in terms of primary prevention of treatment, secondary prevention of patients who come with unstable disease or STEMIs. This is stable chronic coronary syndromes. So the guidelines, as I mentioned moments ago, the latest European guidelines recommend a target of less than 55 milligrams per deciliter for secondary prevention of very high risk individuals and less than 40 in those who have recurrent atherosclerotic cardiovascular events. So what are the management options that we have for the management of hyperlipidemia? Well, it's really statins, Ezetimibe, PCSK9 inhibitors, and Inclisiran more recently, which is now available in the kingdom. When we look at our first line of therapy, statins remains the first line of therapy, and it has been shown in multiple trials, randomized trials over the last 2 decades to reduce major adverse cardiovascular events, both in the setting of primary and secondary prevention. A meta-analysis of over 26 randomized trials has shown a reduction in all-cause mortality, cardiovascular deaths, major coronary events, and stroke, and the range is between 10 to 23% respectively. But we still have to understand that in spite of optimal statin therapy, there is something called residual risk. And this happens in patients who fail to achieve targets on optimal statin doses, such as familial hyperlipidemia or secondary causes, or elevated lipoprotein A. Also, there's those who reach LDL goals on optimal statin therapy, but continue to suffer from atherosclerotic cardiovascular disease. And this is because of other risk factors that are poorly controlled, such as diabetes or chronic kidney disease. And then those in whom we fail to achieve optimal statin doses because of adverse events, such as muscle pain, liver dysfunction, etc. And so this is where, having combination therapy with Ezetimibe, for example, is recommended, and it is endorsed by the guidelines. Ezetimibe in the IMPROVE-IT trial is the most important, where it was added in combination with simvastatin, showed a reduction not only in the absolute LDL level by up to 50 milligrams per deciliter, but also reduction in major adverse cardiovascular events in patients who presented with an acute coronary syndrome, and of course has a very well-established safety profile. Next is the PCSK9 inhibitors, and the current guidelines recommend it in very high-risk atherosclerotic cardiovascular disease on patients who have maximally tolerated statins alone or in combination or fail to reduce their LDL levels, patients who are at very high risk of ASCVD and are intolerant to statins, or those with familial hyperlipidemia without clinically diagnosed ASCVD. Of course, the trials, I don't need to remind you of them, the FOURIER trial and the Odyssey trials respectively have a very important follow-up period of over 3 years now. When it was published, it was approximately 2 years for both. There is a significant reduction of the LDL itself, but it's also coupled with a reduction in major adverse cardiovascular events. The FOURIER had a composite primary endpoint of cardiovascular death, MI, stroke, and hospitalizations for unstable angina and revascularization by 15%. Similarly, Odyssey had an LDL reduction reaching 47%, which was sustained, and the reduction in outcomes in all-cause mortality in patients who presented with acute coronary syndrome. So now we've seen the whole spectrum with PCSK9 inhibitors. Inclisiran, I'm perhaps not the most qualified person, although I have started a few patients on Inclisiran. The Orion series of trials were randomized trials that looked at Inclisiran in patients with cardiovascular disease and persistent elevation of LDL or events. We've seen its safety, we've seen its efficacy, and a reduction in cardiovascular events has also been noted in the early publications by Prof. Ray and his colleagues, but we're still waiting for longer outcome data. This was in the short term. So moving on, Saudi Arabia has actually elaborated the 2022 guidelines for the management of hypercholesterolemia and took all of this in mind, where it looked at awareness, looked at lipid clinics, and so on. And I'm sure these will be published very soon, but they have actually been completed and elaborated. So we move on now from the individual patient and the individual healthcare physician. Let's look at the public sector and their role. Their role, as I just mentioned, is providing the services in the lipid clinics, providing licensure with lipidology boards, for example, and of course, expenditures and focusing on primary and secondary prevention efforts. When we look at expenditures per se, when we look at the World Health Federation's cholesterol roadmap, the aim by 2025 is to reduce ASCVD by 25%. And so this has become a target worldwide and certainly here in the kingdom. In terms of the economic perspectives, the healthcare spending in KSA was $27 billion in 2005. About 20 years later, it's increased to close to 50%. to 50 billion. Most developed countries spend about 85 to 90% of their healthcare expenditures is allocated to secondary prevention, whereas primary care interventions account for only 5%. So this isn't unique for the kingdom. It falls exactly where the rest of the world falls in terms of expenditure. Economic considerations have been excluded, generally speaking, from most clinical pathways guidelines. And in recent exception was the cost effectiveness analysis for PCSK9 inhibitors, which was actually included in the ACCHA guidelines of 2018 and in the KSA lipid guidelines of 2022. The cost of prevention and drugs is generally lower than invasive procedures and hospitalizations. And this is where I remind you of this slide that I showed you earlier, that actually drugs can actually be less expensive when given alone, as opposed to giving them with stents and so on. And in terms of the kingdom, fortunately, when you look at the public spending, which is the blue bar over here, it's still supersedes that for other expenditures such as voluntary and out of pocket. And the kingdom has most certainly prioritized it as a matter of GDP per capita. And when we look at domestic and private expenditures, out of pocket expenditures, general government expenditures, you do see variability. Nevertheless, the government expenditures continues to go up, which is the right-hand side over here, over the last decade. But more important is to understand a few novel concepts that even were new for me when we were first looking at an initiative that I published in 2021 with my colleagues, providing incentives at the individual and institutional level. For example, physician bonuses, hospital allowances, and pay for performances. Conducting post-marketing surveillances and cost-effectiveness analyses, very important, and they are aligned with the 2030 vision that was elaborated by the kingdom. And finally, designing quality rating systems that permit us to rank specialized primary care and lipid centers and hopefully improve diagnosis, treatment, and adherence and identify discrepancies in our patients and in our systems. But important challenges that we face is the different definitions of quality of care by physicians. The lack of patient and physician education, and a lot of misinformation about side effects and adverse events for statins, for example. The fragmentation of healthcare. We do see that the Ministry of Health does not communicate very well with the Ministry of Defense, with higher education, with private, etc. And the disjointed system creates parallel systems, parallel lines, and no standardization of clinical pathways and policies. But what are the solutions? Well, the massive transformation defined by Vision 2030 actually created a roadmap for all of us to work with. The establishment of a National Center for Health Technology as an independent entity to maximize the efficient use of resources. And then streamlining services and creating a unified system. So where we start is prioritization matrices and looking at, for example, the density of physicians per population, what is it in the Kingdom of Saudi Arabia, and understanding how we can create surveillance for risk factors, but you need your healthcare workers, including physicians in particular. And this is what I find very important, is establishing results-based management culture. So when we have results, this is how we improve. Without tracking results and outcomes, it's difficult to do. So going back to where I started a few moments ago, looking at collaborative responsibility or collective responsibility. What do the recommendations say from this publication, as I mentioned, that was actually in 2020? Prioritizing primary prevention programs. Yes, we are prioritizing it, and you're saying awareness has improved, and certainly amongst the general population. And developing the guidelines, as I mentioned, they were published, elaborated in April of 2022 and hopefully published soon. Addressing the gaps, yes, certainly identifying the gaps and addressing them in medical education is something that has happened. And understanding that it's a balance for non-public efforts along with public efforts. But creating referral centers for lipidology is something that is still pending and we need to address. Creating a unified electronic medical record is something that still needs to be addressed. Providing incentives, it still does not exist. And aligning the post-marketing surveillance and cost effectiveness with Vision 2030. It's in the pipeline, but it's still yet to be done. So when we look at individual medical societies and the Saudi Commission for Health Specialties and so on, prioritizing the primary prevention efforts, creating wide-reaching primary prevention and raising awareness in the general public, we've seen a lot of these activities happen, many that were done in association with industry and the Saudi Heart Association, for example, and developing collaborative efforts to endorse societies and the public entities. Again, we're seeing a lot of these programs take off in terms of looking at risk calculators and so on with the Ministry of Health. Incentivizing and training through the Saudi Council certification, this is something that still needs to be approached, and perhaps it needs to be done at a much higher level. Devising CME programs that create specialists and experts in the field, and generating local data where we capture what we're doing, how we're managing our patients, and how well we're reducing events. That is yet to be done. Although the guidelines have now been written, what happens after the guidelines is still pending and in the pipeline. In terms of the healthcare professionals, recognizing the importance of LDL in the genesis of progression of atherosclerosis, addressing the gaps in medical education. These are all work in progress and they have to continue. Identifying patients with high LDL, this is not going to happen once. Our patients change over time. The same patient who was at low risk maybe 5 years ago may now be at higher risk. And so this has to continue. Dispelling the myth of association with dangers of achieving very low density LDL. Again, it's a work in progress. We're seeing some improvement, but it still needs to be continued. And then establishing sufficient primary care clinics that are distributed across the kingdom and its vast territory. Optimizing and standardizing the pathways. Again, it's a work in progress. We need to disseminate the guidelines, speak the same language, set the same goals and targets, and create specialized referrals, as I mentioned, with nurses, dietitians, nurse practitioners, pharmacists, lipidologists, cardiovascular specialists, etc. And creating a unified healthcare record. The Ministry of Health is certainly working on it. And I know that hopefully by the end of 2022, perhaps 2023, we will be seeing something like that. So finally, special gratitude to the Saudi Health Council for all these initiatives that it has endorsed and sponsored over the course of the last 6 months to 1 year. And I think it is a work in progress. We're going to hopefully see more. Thank you for the invitation. And it was particularly honorable for me to be amongst you here to talk about a topic that is very close to my heart. Thank you very much.
Thank you, Professor Merfet. Now we open the floor for discussion. Let me start with our professor from Italy. You mentioned in your talk about the lipoprotein little a. When do we have to screen for it and when we have to look for it, if you don't mind, please?
Well, according to guidelines, you will have to check LPA in everyone at least once in lifetime, given the fact that levels of LPA are genetically determined to a larger extent, from 70 to 90%. Having an idea of how much LPA is there, it's important. There is LPA is causal, independent of LDL, and therefore would be important to know the levels. The distribution is skewed. The vast majority of people have relatively low levels of LPA. In Caucasians, the average in the population is in the range of 10 to 15 milligrams per deciliter. And it's estimated that 20% of the population has levels above 40 to 50 milligrams per deciliter. So at that level, you start to be worried about the levels, and you may consider, for the time being, to be more intensive in reducing the other risk factors. And when drugs that will decrease LPA be available, according to the patient and the risk of the patient, to also reduce LPA.
The new current therapy we have, don't they really decrease the lipoprotein A, the PCSK9 and the Inclisiran? Do they reduce the level of lipoprotein A or not?
They do, about 20%. Whether this is enough, it's difficult to say. As I said, 20% of a low number, let's say average population, because in the studies were not selected to have high Lp(a), let's say 20% of 20 milligram per deciliter is roughly 4 milligram per deciliter. Will that benefit someone? I doubt.
Okay. Dr. Merfat, please, regarding the lipid clinic, you mentioned that hopefully one day we will have a lipid clinic. Nowadays, we have this management of hyperlipidemia is really being distributed by different subspecialties between cardiologists and internists and endocrinologists and nephrologists. So who will run this clinic in your estimate, and when do you expect them to be available?
Well, we've actually discussed this with the National Health Center and the National Cardiac Heart Center. And I do believe there's a genuine interest to establish these centers. Now, generally speaking, a lipidologist is somebody who has lipid boards and is certified in it. And ideally, those are the people that would be running it, but they don't run it in isolation. They would run it with a diabetologist, they would run it with a cardiologist, preventive cardiologist, they would run it with a dietitian, they would run it with cardiac rehab as well. So it's sort of like a multidisciplinary team that actually runs it. At the moment, as you mentioned, Prof. Arafa, the people who are actually running the lipid management in the kingdom are primarily cardiologists with endocrinologists, but primarily cardiologists. And a lot of the discussions that are happening at the level of cardiology. In fact, subspecialty cardiologists and not only cardiologists.
Great. Professor Capitano, regarding your looking at the initial level of the LDL in the patient and the planning to start combination therapy, the guidelines usually say start high statin and then add Ezetimibe, and then think about adding bisphosphonate or Inclisiran later. What do you think about those patients who come really initially with very high level that really would not be expected despite the dose of high intensity statin and Ezetimibe will reach a target? What do you think about early triple therapy?
Okay, I can give you two types of answer. One is the official answer related to the guidelines, where you have to comply with level of evidence. And the level of evidence is suggesting to approach first with a high intensity statin, perhaps with Ezetimibe, and then add a drug that decreases. However, what we do in clinical practice is a different story. For instance, here in Italy, if we have a person, let's say a person with FH, familial hypercholesterolemia, which is, as I understand, quite frequent also in the kingdom there, we start immediately with triple therapy because we know from 250 we will never ever get to goal. So that's what we do in practice. So we don't obey under some circumstances to the guidelines because we know we will not make it and we lose time going step by step. So we do it all at once.
Great. Dr. Mervat, regarding the new guidelines which you mentioned, which have been prepared and ready to be really distributed or published in the kingdom here, can you give me just the main difference between your guidelines and the one, let's say, European or at least the established? Nowadays, we are mostly of us using European guidelines and some of us using American guidelines or the Canadian. How do you find our own guideline will be different in reality and in application?
So the Saudi guidelines are actually quite aligned with the European guidelines. And the reason they are is we all know that the age of onset of atherosclerotic cardiovascular disease events in the kingdom is actually mean age of 55. So it's actually almost a decade younger than our counterparts in Europe and North America. And we know that it's about lifetime management. So the sooner you start, the better. So in terms of targets and goals, it's actually much closer to the European with very stringent requirements of 55 for high risk and 40 for somebody who is a second event that they've had, at least a second event within 2 years, whether it is an MI or whether it is a cerebrovascular event or what have you. The only real difference with the European guidelines is that the Saudi guidelines recommend combination therapy up front. and not to wait to escalate it, primarily because of, as I said, our patients are much younger at presentation, and it's probably wise to hit it hard and hit it early.
Great stuff. Now, going back to our Professor Capitano, about the Da Vinci trial you mentioned in your talk, that this is a recent trial and the history involving quite a good number of patients, and yet the target is not there. And you mentioned there are many reasons behind it. Yes, I want to know from your own experience, what makes your patient not to reach the target in Italy, especially in your practice? What, I mean, is it really compliance? Is it really the system? Is the patient? Is it the medicine we're using? So what exactly you think that the most important part of the story of not achieving the targets?
Okay, let me make one point. That is, we run a lipid clinic, so we have a dedicated person to the patient. So we are in a almost ideal situation, which is not reflecting the situation where cardiologists and other physicians participating into those surveys are. Having said that, we do face in a few patients not being able to reach the goals, but I must say in the vast majority with the armamentarium of drugs we have available nowadays, you are able to reach the goal, even in the most complicated FH. We have patients starting with 450 of LDL, whereby giving statin, Ezetimibe, a PCSK9 inhibitor, Mipomycin and Lomitapide, because both of them are available here, we can get the goal they have below 50.
Okay, great. Now going back to Professor Merfet. Now regarding the incentive, I mean, just I want you to elaborate this. I mean, do you think that in the private practice, we have some role if that is not applied in a common general hospital or the Ministry of Health? Do we have some role in applying this to the private sector, that those who reach a target will be given more incentive for their work? Or what do you think that this might help in the future?
So the private may be a little bit tricky, but because insurance and reimbursement is factored in. But I think what helps is if you actually have guidelines that have already set targets for you. So if the guidelines are telling you that you need to reach this target, it makes it easier for individual physicians to prescribe and to prescribe combinations or to quickly escalate the therapy. For public sector or public facilities, healthcare facilities, I think incentivizing them in terms of budget allocations, if you're meeting your targets, then perhaps, yes, you do qualify for a different budget bracket, and perhaps penalizing, or not penalizing, but I mean, you can't upgrade to a different bracket if that's not the case, if you don't meet your targets. So it's really target driven.
Great. Professor, about the Inclisiran small interfering molecule, how would you foresee the future if you compare it to the current therapy now?
I mean, there are so many factors that depend on the success of a drug. First of all, Inclisiran is as good as the PCSK9 inhibitors. Inclisiran reduces the synthesis, doesn't inhibit PCSK9 directly. The level of reduction of LDL cholesterol is comparable to that with the monoclonal antibodies. And at least in many countries will depend on the level of sustainability. In other words, the cost of the drug as compared to the others. Certainly, there is the advantage of twice-a-year injection as compared to every second week, which might make a difference in terms of compliance and capability of the patient to adapt to this kind of approach. In terms of safety, there are no signal whatsoever from all the trials that have been performed so far. The only signs are the typical ones when you inject something subcutaneously, which is true also for the monoclonal antibodies, but nothing else. So the safety is quite good as far as we know. As I said, it will depend on the cost and reimbursement procedures worldwide. I suppose that we have experience with only a few patients in a small trial. The acceptance is good, it's very good, because there is no major problem there.
Great. Now, in order to follow up the patient in your, I mean, to give a patient now injection after 3 months and 6 months, is there any way that the patient will be tracked in your, I mean, do they be reminded that there's injection is due? Do they have to be follow up? I mean, because the problem here, especially in the kingdom, we have a wide distribution area of patient location. Some of them living in the city, some of them out of the cities. So how do you track the patient in order to get them to come to their time for the second dose or third dose?
I think the only way to do that properly would be an appropriate system that sends reminders to the patient, and you contact that by the phone and tell them, guy, remember, 2 weeks from now, you have to come here to get your drug.
Okay, and when do you usually check the response after the first loading dose? After, I mean, you did it today, injected them with the time today.
Yeah,
You
I
check
think,
it in 3 months or 6?
oh, even 1 month would be enough, but between 1 month and 3 months, that would be okay.
And then when do you do it again?
What do you mean, after the injection?
Yeah, after, you did it now and you are happy that the level is reduced. Do you to have to check it after 6 months again or after 1 year again?
Well, you have to check it, I would say, in the chronic status, I will do once a year with Inclisiran, because the duration of the therapy is quite long-lived, so should be no problem. Once a year will be more than enough. Take the advantage of the opportunity the person is coming to take the medication, and or even use this, you know, this very are not very accurate, but you can do by the drop from your fingertips and check cholesterol and see whether it's more or less stable. If something has occurred, you will be alerted.
Some people are saying that we should wait for the outcome data before we could apply it widely. What do you say to them?
These are hardcore people in terms of evidence. I think my position is the following. I have no doubts that by decreasing LDL, you will get the benefit. That has been demonstrated over and over with thousands of different interventions. Yet, the long-term trials are important for safety, because you can do the good of reducing LDL cholesterol, but can do harm by side effects that are unrelated to the mechanism of action, but specific to the molecule. Inclisiran to date has a very good history in the phase 1, 2, and 3 studies. We do not have the long-term outcome study, so some effects may come up. Personally, I don't believe, because the story is very good, but still it might come. But this, in my view, these trials are no-brainers if the drug is safe as it appears.
Fair enough. We have only left 2 minutes. Just let me give the final word from Professor Arcano and Dr. Merfet. Final word, your home take message for our people. We have more than 500 attendees today in the meeting today, very vast majority. What's your home take message, Professor Capitan? One sentence.
Okay, LDL is causal. Try to reduce it and keep it down. Don't stop therapy because you're happy with the level that has been reached, because it goes back and the risk goes back immediately.
Thank you very much. Dr. Merfet?
I would say, well, happy Friday, everybody. I would say engage your patients. As long as they're engaged, they will become your partners in the care of their lipids. And they will learn to manage their lipids in addition to the drugs, of course, with lifestyle modification. So they will hopefully eat right, exercise, and so on.
Thank you very much indeed. It was really a pleasure to have both of you today. And thank Novartis for their support always for the continuous medical education. And thank for the Heart National Center for this program. Hopefully we'll see you more in the future. Definitely we have to take our patient, reduce their mortality and improve their outcome. All the best luck for you and have a good weekend. Thank you, Professor. Thank you, Dr. Mervet. All the best luck.
Hi, everyone. Take care.